Just a reminder when we talk about chapters 58 and 59 with sensory disorders, whether you can't hear, you can't see. So, what's the purpose of us being able to hear and see? What's really the purpose? What else? Very good. So, what's the basic thing? What could possibly happen if what's the worst that could happen if we can't see or hear?
Injure ourselves.
Okay, it's really for safety, correct? Right. So always think about safety when when you deal with any of these disorders, right? And then some of them, of course, or yeah, some of them have medication. So we talked about cataracts, glaucoma last week. So these patients will be on eye drops forever. And then we talked about how to administer eye drops because you're going to be teaching the patients these as well as the ointment, teachings about the consequences, what would happen if they stop taking these eye drops. Okay, and now let's progress with other disorders that now require surgery. Okay, so cataracts is one of them. What is cataracts? Contrary to most people believe, uh, this is not only age related. Okay, there are younger people who get cataracts. Age is simply one of the causes of cataract formation. So there are conditions, especially chronic conditions like diabetes, for instance, that can cause cataracts. So this is lens opacity or cloudiness. The lens covering our eyes are supposed to be clear. It's like a glass window. The purpose of that lens, of course, is to protect the cornea, okay, from any injury, from dust or other debris. Okay. So a few factors can cause it to become cloudy. And just like our car shield, for instance, our windshield, or our eyeglasses, they can get dirty, correct? So when that happens, can you still see? Okay, so they become cloudy and then we need to clean it. Here's a picture of cataracts, unless you've seen one in your elderly family or some patients, for instance. So that's supposed to be clear. It's just not supposed to see the lens at all. It's supposed to be transparent. Now it becomes opaque and then cloudy, and then the severity of this, of course, will determine how much vision you will have, how much vision impairment you'll have. So since it occurs in the middle, it doesn't have to be a perfect circle, by the way. Some cataracts will have different shapes, especially early on. It's not always a uniform cloudiness. Could be a shape of a yin yang, for instance. Okay, so it can vary from person to person. So most complaints, once the patient already has a full-blown cataract or what we call a ripe cataract, ripe like a fruit, ripe, its onset is actually insidious. So the version will just go blurry and blurry over time. That's the number one complaint is blurry vision. There's no pain associated with cataracts. So now the patient will have to make adjustments. So they're not aware of it because, again, the development is very slow over several months, over several years. They just learn to compensate. Okay, so depending on which vision is impaired, whether it's a full central or a little bit peripheral, or maybe you have a little few blind spots because your vision again is blurry. So the patient learns to compensate, okay, to continue seeing uh, despite the impairment. So there's light scattering, glare, especially with bright lights. There's double vision as well, color changes. The diagnostic test, of course, is visual examination of the lens. So your optometrist can diagnose this, but of course the optometrist can't do anything about it. So you'll have to go to a ophthalmologist who will be the one to cure the cataract. So unlike glaucoma, which doesn't have a cure, cataract is curable by surgery. There are no eye drops that can clear the opacity. All we can do is remove the lens. Then depending on your specific condition, you may or may not get a lens implant to replace the lens. Now, the medications and eye drops, you will be prescribed some eye drops. However, they're not to cure or treat cataracts. It's actually a post-op protocol, meaning after surgery, are you prone to inflammation? Because they did surgery on your eyeball. So is there going to be any inflammation? Because they use a scalpel to remove the lens. So is there going to be any swelling? Is there going to be any redness, inflammation? So you will be given, are you prone to infection? Yes, so you will be given eye drops in the form of antibiotics, anti-inflammatory. All right, so these are for post-op care. But how long are you on the eye drops? Forever? Only a few days. Are we clear? Okay, so you're still taught to administer eye drops, you or a family member, but are these for the cataract itself or for the eye surgery? It's a post-op routine protocol. All right. Okay. Not all patients are candidates for surgery. As mentioned here, there are people who have to wait. For instance, especially if you're diabetic, and then because describe the circulation in the eye. Are the blood vessels very visible? Can you see the capillaries? I mean, can you see your retina? Okay, so if these eye structures are very fragile and very small, so are the nerves and the blood supply. So therefore, the diabetic must have optimal glucose control, because will it heal if there's poor circulation to the eyeball? No. The higher your blood sugar, then the more the ophthalmologist will not touch you. They won't perform surgery. They will demand that take good control of your glucose first, and then we'll do surgery. Okay, because are they responsible if your incision, if the surgical site doesn't heal? Yes, they will answer for the complications. They shouldn't have done surgery in the first place when they knew that the diabetic patient is not taking the glucose under control, because they should have known that it will not heal the incision. Does that make sense? Okay. There will also be eyeglasses most of the time. Now, the eyeglasses is not really for vision correction. These eyeglasses are for protection. Okay, these are more like goggles. Okay, because what will you do in your sleep? Because what will the surgical site feel after surgery? And will it be itchy? Yeah. Okay. Will there be tearing? And what will you do? Unconsciously, you're gonna rub it. Okay. So rub a surgical eye, and what will happen? Okay, so that's why you wear these goggles, okay? So that at least in your sleep, unconsciously when you try to rub, you can't touch it because you're wearing the goggles, okay? But they're not really eyeglasses, okay? Then you'll be advised to wear sunglasses outdoors. Again, tight glucose control, smoking cessation would also help losing weight, because again, that will impair circulation to the eye. The surgery is outpatient. I mean, just takes 1 hour to do the surgery. Then you go home. Then you follow up outpatient. Here are the risk factors. So age is just one of the risk factors for cataracts. There are many others. Here's a complete list: infection, retinal detachment, right? So there are many factors that can increase the likelihood of cataract development. And these are the complications of cataract surgery. Included in this list are retinal detachment, which will be part of the last topic later today. There's also bacterial infection, go straight to because the procedure, there's no question on because are we doing the surgery? No, the ophthalmologist is. So all we're concerned about, our duty is pre and post-op, especially post-op care. Now, the post-op care mentioned here is not different from any other eye surgery. So moving forward, because now after this, we will go on to retinal disorders, which will require surgery as well. The post-op care will be exactly the same because is it a different eyeball that they're doing surgery on? Exactly the same. So pre and post-op care will be the same. So patients will receive eye drops as well before and after surgery. Okay, let's focus on post-op care. Chart 58-9. So here are your teachings. So you tell them about the eye drops because they will be prescribed eye drops. So explain to them what each one is. So expect that they will be prescribed antibiotic eye drops, steroid eye drops, or other inflammatory eye drops. There will also be miotics because we want the pupils to constrict. Warn them against activities that require, good vision. Like, can they drive? Is it safe to drive home with only one eye? Okay. And weightlifting. So the restrictions for activities here are the same as with brain surgery because where is your eyeball? It's still inside your skull. Okay, so uh, post-op care for eye and brain surgery is the same. Okay, activity restrictions are the same. So whatever increases intraocular pressure also increases intracranial pressure. So activities that are prohibited are the following: lifting weights, driving a car, contact sports. What else? What are you doing when you lift weights? What are you doing when you're straining? You are okay. So why does the pressure rise? Because what are you actually doing when you're lifting weights, when you're sneezing, when you're coughing, when you're singing, or when you're having sex or giving birth, for instance? What are you doing with all these activities? Bending down. What is common with all these actions?
Oxygen is stopping from going.
Oxygen or breathing. Okay, so what you do is you take a deep breath and then hold it, correct? When you're having sex, are you doing that? When do you take a deep breath and then hold it? Yeah, when you give birth to a turd, are you doing that? Yes, because otherwise, how can it come out, right? You have to, right? Okay, same thing. Yeah.
Drowning.
Oh, right. So when you're coughing, sneezing, the same thing. Okay, you inhale deeply and hold your breath. Same thing when you pick up something, when you bend down to pick up something, when you're pushing and pulling, you have to take a deep breath and hold it. So all these activities are prohibited when you are post-op for eye or brain surgery. Are we clear? So you don't have to memorize everything. So just examine, does this activity require any pushing or pulling? If the answer is yes, then that will increase IOP, that will increase ICP. Are we clear? There will be drainage, of course. Every time you have any irritation, including surgery, so the eye will be itchy. There will be drainage. You'll be tempted to rub it. If you must rub it, just clean away because you have discharge at the inner or outer canthus. So just lip with a clean tissue. Okay, gently wiping it, but never rub it. Can I get my eye wet?
No.
No. The surgical eye must remain dry. So what do I do? Can I take a shower?
I would.
Can I take a bath?
You can take them back.
A bath is okay because it's, you don't submerge your head, right? When you're taking a bath. But a shower, probably not a good idea because water will run down your eye. So can you wash your hair?
No,
You have to go to a salon, right?
Yeah.
Because they have that sink, okay? But otherwise at home, it's gonna be impossible, okay, without getting the surgical eye wet. And how do they position when they sleep? Lie on where? The opposite eye, okay, on the opposite side. So avoid lying on the side of the affected eye. You can do ordinary activities, but again, what are restricted? Driving, sexual activity, and any strenuous activity. Again, any activity that requires pushing and pulling. Okay, what symptoms to report? Vision change, continuous flashing lights. These are signs and symptoms of retinal detachment, which is possible whenever you do eye surgery. So whenever you mess with the eyeball, you risk retinal detachment, which is usually caused by trauma. And eye surgery, is that traumatic? Yes, very traumatic. The vision after surgery will improve. Of course, from before the surgery, the patient had near total blindness, right? Very blurry because of the cataract. After surgery, it should immediately be better. But full clear vision is not achieved until several days after surgery. Because why? There's still a lot of swelling, inflammation. So what will the eye look like after surgery? Is it going to be like right now, clear, white? Okay, it'll be bloodshot. Okay, of course, again, the doctor put a scalpel to the eyeball to remove the lens. So of course, there will be a bloodshot appearance, and that's completely normal. The drainage or the discharge must be either clear or white or crusty, but any other color except white, like yellow, green, brown, that's a sign of infection and must be reported. So when they say vision change here, if the vision worsens, okay? Because of course we expect the vision to be way better after surgery. That's about it. Any questions on cataracts? Sorry?
Laser.
No, LASIK surgery is only for astigmatism, that type. It doesn't, this one requires a scalpel. So full vision is achieved 6 to 12 weeks later, meaning every week your vision will get better and better as the swelling goes down. So refractive surgeries, this is where LASIK is mentioned, but we're not testing that. We're only doing. Reason is LASIK surgery is more elective. Okay. All right. Retinal disorders. Let's start with detachment. This is more common than we think, especially in the elderly. Now, one elderly that we do some stupid things sometimes, right? We hit our head on something. Let's say we bend down, we know there's something there, but then we bend down, but then we underestimate that, you haven't cleared it yet, and then you hit your head. So as simple as hitting your head, a significant blow, blunt force trauma to the head is enough to cause retinal detachment. Okay. Number one example is my father-in-law. All he did was reach under the sink to get something, and then he hit his head quite considerably. And then after that, he saw some floaters in his vision. He ignored it because it did disappear after a few days. And then little did he know that he had retinal detachment. So now he's blind, totally blind on his right eye.
Hmm.
And the guy is very stubborn. He still drives. So watch out.
Man,
You might share the road with him. So here's retinal detachment. So the retina is, again, that part with the yellow border. That's supposed to be a lining, okay, on the all over the surface of the eyeball. It's supposed to be attached, so that yellow line is supposed to be attached. Okay, so think of it as skin that being ripped off. Okay, so think of it as skin. Okay, so let's imagine this is skin. So this is skin being peeled off. And that is the retina. So this part here is supposed to be stuck to the wall of your eyeball. But due to trauma, including eye surgery, that can tear, okay, and then detach from the eyeball. So of course, as you tear that, what will appear here? Because now you have space. There will be bleeding here. Some bleeding, not a lot, it's not gonna be hemorrhage, but of course there's some bleeding. So this is what you see as floaters. Okay, so right after the incidents, after you sustain the trauma, let's say you got hit by a baseball, or let's say you hit your head, on something bending down. So the moment it happens and then it detaches, of course, there's some blood. So what you saw as floaters are really specks of blood in your vision, because of course they will float here. So as light is reflected, you'll see, oh, what are those? Okay? You see, what are those floaters in front of my eye? So that's the number one symptom of retinal detachment. Of course, the bleeding won't be there forever. It'll just last for, a few hours, maybe a few days, and then it'll disappear. Then your vision will be impaired now. So here's the most reported manifestations. So sensation of a shade of curtain coming across the eyeball. Okay, so again, the retina, you can't see without the retina. So if you peel off the retina from the eyeball, of course you can't see. So there'll be cobwebs, bright flashing lights, or floaters, as already described. There's really no pain here. The only pain would be from the trauma that you experience whenever you sustain the whatever trauma that caused the detachment. Assessment diagnostic findings. Of course, the ophthalmologist has to see your eye. And then the management, of course, we have to reattach the retina. Okay, there are a few ways to do this, depending on how bad the detachment is or how much of the retina was detached. Most common way is scleral buckling. Look at this picture. That's your eyeball, and they put that silicone band. It's all around your eyeball. Okay. Now, it's good looking at it at a picture, right? Now, imagine how did they get that silicone band around your eyeball? Imagine what they have to do. Do you want to see it? Okay, I don't want to see it either. There are videos on YouTube if you're really interested, but I don't want to watch it because I tried, it makes me cry. Okay, it's very traumatic. The number of instruments and how they handle the eye, because there's going to be 6 instruments that will be inserted into your eye socket in order to move the eye muscles, because they have to move the eye in order to put the buckle around. Can you picture what I'm saying? I mean, you have to go in and then insert that buckle, that silicone band. They have to insert it inside your eyeball. Now, again, imagine what they have to do in order to do that. So when they do that, of course, that will reattach the retina back in place, and that will be there permanently.
So just squeezing the eye to get the retina that's detached back, attached.
And then that's during the surgery. And then imagine what will happen after surgery, how your eye is going to feel, how your eye is going to look, okay, after all that trauma. Another option is to put a gas bubble, inject a gas bubble. So this is less invasive, okay, compared to the scleral buckling. This is really traumatic right here. This one will involve, of course, a needle. So they'll inject it into your eyeball and then administer a gas bubble. Now this gas, I forgot the name. It's hard to pronounce. But anyway, the gas bubble here, sometimes it's a silicone oil. Okay, it's either an oil or a bubble. But most commonly they use a bubble. Now this bubble is dense. This gas is dense. It's not like air. Okay, it's not like room air. So it's still a gas. So therefore, what will a gas do? Go down or go up? It will always float up. So when they inject the gas bubble, of course it will rise. So once it rises, will it now press against the tear? Yes. Let's say this is the tear, right? So when they put a big bubble here, of course, when it rises, it will push the retina against the wall. Okay. However, if they do this, the patient, of course, the ophthalmologist knows where the tear is. So they will tell the patient to hold their head in a certain position in order for the gas bubble to press against it. Does that make sense? Meaning if the tear is on this side, where will the bubble go? The tear is on this side of my eye. So if the gas is here, where will it go? Straight up, right? So what position do I need in order for it to push on this side? I need to turn my head this way so that the gas bubble goes here and then it will press against the retina. Does that make sense? Okay. Yeah, so therefore the patient has to hold their head in a certain position like all the time. Okay, so they can rest maybe, oh, I'm too tired. So they can rest maybe a few seconds and then go back. All right, go back to that position, that prescribed head position, especially when they're sleeping. So when they sleep, they have to hold their head in a certain position. Does that make sense? Okay, because otherwise the surgery won't work. So we got scleral buckling, and then what I described is vitrectomy. And what are the pre and post-op care? Is it any different from cataract surgery? Exactly the same. So same precautions, same teaching, same activity restrictions. Okay, let's go now to macula. So this will be the last part. We have AMD, age-related. This is the most common form of macular degeneration. This is irreversible blindness due to just wear and tear. I mean, we're old, okay, so this is always age-related. So the older you are, the higher your risk for age-related AMD. Of course, some factors will facilitate the formation or you developing macular degeneration because not all people are at risk here. So definitely some patients who have certain chronic conditions, especially diabetics again. Now, there's no cure for dry AMD. Management is simply trying to preserve whatever remaining vision you have because it's the degeneration of the macula. I mean, can you replace the macula? No. So it's already degenerated. Then what else can you do? The macula is the central part of the retina responsible for central vision. So what type of vision loss do you have here? Central vision loss is lost. Unlike glaucoma, which was peripheral first and then central, this one is central vision loss. You can still see in the periphery, but central vision is gone. The only way again is to give the patient vitamins, okay, to preserve eye vision. The most popular prescription will be AREDS, AREDS. It's only a bunch of vitamins, vitamin E, vitamin A. It's made by Bausch and Lomb. Very effective, okay, to preserve remaining vision. That's all we can do. There is a wet type of AMD. So there's a wet AMD. It's also called there's really no other name for it. It's wet AMD. Unlike dry, which is age-related, wet AMD can be developed by all ages. So what happens here is usually the risk factor is cancer. If you have wet AMD, what you developed are abnormal blood vessels supplying the eye, and these abnormal blood vessels are very leaky. So since they're very leaky, do they really perfuse the eyeball completely? If they're leaky. Okay, so perfusion will be low, right? So therefore that will lead to degeneration of the macula. Okay. However, since this is wet type and develops at any age, there's a cure for it. You will be given VEGF, or vascular endothelial growth factor. This is actually because, again, the characteristic of these blood vessels are like cancer. They're abnormal blood vessels. So what we do is give you this injection, and then the patients will stop growing these leaky blood vessels, right? This endothelial growth factor is a normal protein that we develop when we're in the highest, when you are an embryo. Okay, it's normal in an embryo or an infant, newborn baby. But after the first year of life, the endothelial growth factor levels go down, almost close to zero. So when you start producing this again, the only explanation is you might have either wet AMD or you have some kind of cancer growing inside you, because this is produced usually by cancer cells in an adult. This is how tumors grow. They produce this, and then the body grows new blood vessels to supply the tumor. And that's how the tumor grows. Does that make sense? All right, that's about it. Any questions on eye disorders?
Doesn't hear that. You're awake, so.
Only